Okay. Hey everyone, my name's Anthony, and the disease or infection I chose is tuberculosis. So, what is tuberculosis? Uh, it's basically a bacterial infection that really affects our respiratory system, our respiratory tract, mainly our lungs. It's not limited to only our respiratory system, though it can attack many other parts of our bodies. It can target other parts. Tuberculosis can start as an infection and later on develop into a more serious disease. Um, a lot of people don't even know that they have tuberculosis. Um, in a sense, they have a latency period. They're latently infected. Don't even know they have it, go on throughout their day, and then over the course of time will start to develop signs and symptoms, which I'll be going over later in the presentation. So, like I previously said, tuberculosis affects our lungs and respiratory tract. It can also affect our kidneys, brain, spine, and skin, just to name a few. Usually, in the beginning period of the infection, there are no signs or symptoms. That is because of the way the certain bacteria works in our body and its characteristics. But when it does develop, um, you become more infected and develops into that disease, infectious disease state. You can develop symptoms ranging from chest pain, fatigue, and generalized weakness, fevers, shortness of breath, and one of the biggest things that a lot of people see in tuberculosis cases and individuals, patients, etc., is a persistent cough, a continuous cough that does have the potential for blood to come up with it. Now, these symptoms can start out mild. They can last for a long time as just mild symptoms and then ramp up very, very quickly. And that's what makes it a little less noticeable and easier to spread um, to the community and everywhere. So, like I said, it affects the respiratory system, and that's what a lot of people kind of mainly focus on. But to just talk about some of the other systems and organs that it can target, and that I've already mentioned in the last slide, we'll start off with kidneys. Tuberculosis, the bacteria that causes it can actually travel down throughout your body, throughout your bloodstream, throughout your lymphatic system, and can get to your kidneys. Some symptoms and signs that you might notice are, blood in the urine, painful urination, problematic urinating, things like that. Can also travel into our spine. Now, the only sign and symptom with that is you're going to be having some back pain. One of the crazy things is who doesn't have back pain, right? So that's where we have to kind of figure out, is it just regular back pain or something serious going on? One of those things that it could be going like this, it could be going like that. Something easily missed, and just one of the things that makes it a lot easier to spread. You just think you have back pain. You're out going doing your day-to-day life, shopping, partying, just going out into the general public, um, grocery shopping, things like that. Um, the other thing I talked about was it could, affect our brain. It can travel into our brain. That TB disease would then turn into something more classified as TB meningitis. Meningitis is like infection of the brain. It can cause some confusion, headaches. You can become very altered. It's not limited to just headaches. It can also, meningitis travels with neck pain a little bit, like stiff, rigid neck. And really dangerous high fevers, if I already didn't say that. So I've been talking about this certain bacteria that causes this, and here's a picture of the culprit itself. So right here is what causes tuberculosis. It's bacterium called Mycobacterium tuberculosis. Um, Previously mentioned with some of the signs and symptoms is that they all start out mild, right? And that's because this is a slow progressing type of bacteria. Um, and that's what that makes all those signs and symptoms kind of dragged out in a sense. Um, Primarily, it does focus our respiratory and lungs. Um, and that's because it has an affinity for areas of the body that are rich in blood and oxygen. An example, our lungs. So, it's a small acid fast bacillus that, as you can see, has a rod shape and it's strictly aerobic. What does aerobic mean? Oxygen loving. There we go back again to our lungs and respiratory system. Um, you know, like I previously mentioned, it can spread throughout the body via our bloodstream and also our lymphatic system. It can drain into our lymph nodes and start circulating out through our body that way as well. So, how does it all start? Like, what's the pathogenesis of it? So, the Mycobacterium tuberculosis, MTBC, the MTB, um, it'll be phagocytized by macrophages in our cell tissues, and it'll start to then take over and replicate um, and eventually drain into our lymph nodes. So, our body will have a response to all of that with our own white blood cells, monocytes, and lymphocytes. And it will go to those macrophages and form around them to try to fight it. What actually this um, what actually happens because of this is it makes something called a granuloma, like a hard mass, right? Um, hard mass and a collection of all of the monocytes and lymphocytes around the Mycobacterium tuberculosis. And when that happens, inside of it, the MTBC will continue to replicate inside of the granuloma over and over and over and over again until the granuloma can't hold it anymore, can't contain it, and it'll just eventually break off and spread to other parts of the organs if our immune system can't finish it off there. With all of the spreading and traveling to different parts, it will eventually get to our bloodstream. That's like more of one of the last parts, and it can then re-enter our lungs again and just continuously keep circulating and causing new infections to our bodies as the host, making us sicker and sicker. Some virulence factors with MTBC. Let's start off with mycolic acids. They're these long chain fatty acids, very, very waxy in nature, very waxy coating that will protect the bacterium from antibiotics, like an extra added layer. There's, bear with me on this one, lipoarabinomannan. That's basically a glycolipid inhibitor that will block some of the phagosome lysosomic fusion that takes place in our body, and it will actually allow the MTBC to survive further and replicate further. One of the proteins for its virulence factors is ESAT6. That kind of basically helps the bacterium to escape from the phagosome into the cytoplasm. Kind of in a sense, think of it's like playing tag, but it just doesn't want to get tagged, right? So that's a way that it kind of gets around our own immune response to the bacterium. Another thing we have with it is antigen 85 complex. It's another group of proteins, and these groups of proteins kind of play more of a role in the mycobacterial cell wall, right? It strengthens it and interferes with our body's ability to mount an effective immune defense, right? So, anything we're throwing at it, it's just not working. It's that cell wall has been strengthened or, in a sense, like evasive to any white blood cell or immuno response that we have to it. Another thing, we have cord factors, and cord factors are just simply help form those granulomas. Going into culture and diagnosis, one of the main things that they use for the testing wise of tuberculosis is something called acid-fast bacillus. I mentioned acid-fast bacillus earlier. These are conducted to kind of confirm whether or not one has it or not. Basically, individual will provide a sputum sample. Sputum is mucus or phlegm. It's not just spit. It's a little bit more than that. And there's a couple different ways they can go about it. They can do a smear test, something we're familiar with in class, right? You take a glass slide, you smear the bacterium or the media or the culture or whatever you collected, heat fix it, all of that good stuff, review it under a microscope. 1 to 2 days, they can basically determine whether or not there was the Mycobacterium tuberculosis present on those slides. Now, this cannot provide a diagnosis, even though it can come back positive and is a good sign that it, could be tuberculosis. They cannot provide a diagnosis just from this test. They can, however, provide a diagnosis from an AFB culture. So, same thing, patient or individual will provide a sputum sample, and that is sent to a lab where the cells will grow within the culture, whether it be a plate or a tube, however they collected it. About 6 to 8 weeks, they will let that grow, see what grows, see the amount of Mycobacterium tuberculosis or and the amount of colonies and stuff, and they will determine whether or not it's sufficient and positive for tuberculosis or it's negative. Something that gets paired with that AFB culture test is a susceptibility test. They do this to kind of find out what the most effective antibiotic course of treatment for tuberculosis will be, right? Because this bacteria, it's actually very drug resistant. A lot of people don't finish out their medicines. I'll get to that later, but yes, this actually is a very drug resistant disease. There's a molecular test that's basically where they take the sample, the sputum sample, they drop a little nucleic acid amplification solution on it, and there is either a positive or negative reaction. Basically, that shows whether or not the bacteria is resistant to rifampicin, which is a common oral antibiotic used to treat tuberculosis. Finally, one of the last tests, kind of commonly used is a skin test. So you'll go to a provider, doctor, nurse practitioner, PA, whoever, and basically they'll have healthcare staff inject a little live tuberculin under your skin, and a bubble will appear. You come back in 1 to 2 days, 3 days, and the provider will then examine that bubble. They'll examine if it grew, change shape or size, if there's any positive reactions going on with your body and on the skin, and that'll basically kind of determine whether or not you potentially have a tuberculosis infection. Going into a little epidemiology and transmission for tuberculosis. So a couple statistics here. There's about 8,300 reported cases in the United States from 2022. Didn't really see a lot from the CDC or the World Health Organization of the more recent years. There's a lot stemming from 2020 to 2022. And, just in the United States alone, over 60 jurisdictions. Even with those 8,300 reported cases, there's probably a good estimated 13 million people that are living with latent tuberculosis infection just in the United States, right? So that latent tuberculosis is where you are infected, but you might not be spreading it, right? You might not be in a spreading phase. So, 1.3 million died in 2022. This making tuberculosis the second leading infectious killer. The number one infectious, leading killer was COVID. So, within that 1.3 million, you see about around 10.6 million are ill, 5.8 million men, 3.5 million women, 1.3 million children. And some of the areas in the world that are heavily affected by tuberculosis is the Southeast Asian region, with 46%, African region 23%, Western Pacific 18%, and then the rest of the world and other regions with around 13%. A lot of that has to do with kind of like along the equator is where you see a lot of environmentally caused tuberculosis. It's like the perfect situation, I guess, in a sense, for it to be kind of grow and be transmitted. Speaking of transmission, it's mainly an airborne transmitted disease. So how does that get spread? Coughing, one of the signs and symptoms. Any sneezing, spitting, even talking kind of can really spread that as well. But that is the main spread, of tuberculosis. With that, we're going to go in a little bit of a statistic right here. The highest percentage of transmission was among the non-Hispanic American Indians with 41.6%, and Alaskan Natives also with an 18.4% from that 2020 to 2021 data that I talked about a little bit earlier. Another quick little tidbit with transmission and epidemiology is that tuberculosis is greatly affects those with HIV. They're already immunocompromised. They can't really hold up their own immune system. So, people with HIV are very susceptible to tuberculosis. And, with that, their antimicrobial resistances present in the body, already fighting everything off. Their body just can't do that. So, you see a lot of people that with HIV that develop tuberculosis, they usually end up not making it. So, it's very important to keep up our health. Prevention is as easy really as covering your mouth when you cough, right? Wearing masks because it is an airborne transmitted disease. Isolating yourself when you're infected. Don't go out to the grocery store. Don't go shopping. Don't go hang out with your friends, right? Don't go to massive, parties, protests, concerts, anything like that. Managing your environment, right? A clean environment, proper disposal of, infected items, right? Tissues, anything you're coughing on, proper cleaning, basically, is what it comes down to. Is one of the great ways of prevention, and always prevention is better than actually getting the disease and curing it, right? So another great prevention strategy right here is the Bacillus-Calmette-Guerin vaccination, the BCG vaccination. That was created around in 1921. And so it's been around for a long time, and it has proved to be pretty effective. It's the only vaccine prepared from a weakened strain of tuberculosis out there. 80% effective for 15 years once you get vaccinated. It's pretty good. It's more effective against complex forms that are in children, but also has a limited effectiveness for those over 35 years of age. Now, it also is less effective in areas where naturally occurring mycobacteria is present from that environment. Talking about that kind of around the equator type of situation, and where I was talking about all the statistics from the epidemiology slides. Finally, we're here at the end of it. Treatment is curable, right? Treatment's curable. Wow. Made it through the whole presentation just to mess up on that. That's crazy. Tuberculosis is curable. The most common treatment is a combination of, oral antibacterials, and, I have the most common ones listed below. You have isoniazid INH, the rifampin, pyrazinamide, and ethambutol. You're never really going to take any of these just by themselves if you have, confirmed positive case of tuberculosis, you're going to take all of these because the Mycobacterium tuberculosis is a complex infection. Like I said, it can be very drug resistant. A lot of people don't finish out their course of medications, and it leads to an increase of drug resistance with tuberculosis. And once that happens, if you have it once, you didn't finish out your course of medications, you get it again, um, or you just didn't get rid of it, it can take up to 20 to 30 months of taking antibiotics, these antibiotics, even more culture testing and specific susceptibility testings to see which ones would be the most effective. And once you introduce your body to certain medications, your body's familiar to it, and who's to say that just because the medications work now for you doesn't exactly mean that they will work in the future if you were to get it again, right? Because you're building up that resistance. Um, while taking the medications, you have to be consistently checked up, by healthcare professionals and providers. It's kind of to be expected to kind of monitor your side effects and treat any really bad side effects. Nausea, vomiting, diarrhea, any adverse reactions, anything like that. Fever getting worse, you potentially getting sicker in a sense. And you also have to get your blood tested during these checkups because some TB medications, most of them, they are toxic to our livers, right? And so we don't want to start causing another problem from trying to fix an already existing problem. We don't want to go into liver failure, get like some, liver cirrhosis or something like that, just because we were taking medicine to treat tuberculosis. So all in all, that was it really. Those are the main points of tuberculosis and Mycobacterium tuberculosis. Hope you enjoyed listening to me ramble. Sorry if it was a lot of rambling, but thanks for hanging in there, and good luck to everybody else on the rest of their projects. References.